Thalassemia is actually a hematological disorder, and the normal hemoglobin, it consists of two pairs of amino acid chains, one pair of alpha chains and non-alpha chains or the beta chains. So, adult hemoglobin HbA consists of two pairs of alpha chains and two pairs of beta chains. So, HbA is represented as alpha 2 beta 2, and the fetal hemoglobin consists of two pairs of alpha chains and two pairs of gamma chains. So HbF is represented as alpha 2 gamma 2, and HbA2 consists of two pairs of alpha chains and two pairs of delta chains. So HbA2 is represented as alpha 2 delta 2, and if any of the Hb chains are deficient or if they are abnormal, then it can lead to thalassemia syndromes or abnormal hemoglobinopathies. So if HbA will consist of alpha to beta 2 chains, HbF consists of alpha to gamma 2 chains, HbA2 consists of alpha to delta 2 chains, and if any deficiency or abnormality in these Hb chains will lead to thalassemia. So classification of thalassemia syndromes: the thalassemia syndromes are classified as alpha thalassemia and beta thalassemia. This alpha gene is located on chromosome 16 and beta gene is located on chromosome 11, and this thalassemia is inherited as an autosomal recessive disease, and there is a 25% chance that children born in each pregnancy will develop a thalassemia major. So thalassemia is classified depending on the deficiency of type of globin chain of the hemoglobin. So there are two globin chains in Hb, one is alpha and other is beta. So if alpha is deficient, then it is called alpha thalassemia. If beta globin chain is deficient in the Hb, then it is called as beta thalassemia. So alpha thalassemia, alpha thalassemia, there are actually four types: silent carrier, alpha thalassemia trait, HbH disease, hemoglobin H disease, and hydrops fetalis. So first type of alpha thalassemia is silent carrier, where there is no anemia and the red blood cells are normal, and there is presence of 1 to 2% of Hb BARTs at birth. And regarding alpha thalassemia trait, the second classification of alpha thalassemia, that is alpha thalassemia trait, the patient will be mild anemic and hypochromic microcytic red blood cells will be present, and they will possess for 5 to 10% of Hb BARTs at birth. Then the third classification, the third type of alpha thalassemia is HbH disease or hemoglobin H disease, where there will be moderate hypochromic microcytic anemia, and the patient will have 5 to 30% of HbH. And the last type of alpha thalassemia is hydrops fetalis, where there will be death in utero caused by severe anemia, and predominantly Hb BARTs will be present here, and small amount of HbH will also be present. So this is about alpha thalassemia. The four types of alpha thalassemia include silent carrier, alpha thalassemia trait, HbH or hemoglobin H disease, then hydrops fetalis. Then beta thalassemia also has four types, which include silent carrier, thalassemia trait, thalassemia intermedia, thalassemia major. So silent carrier type of beta thalassemia, they are actually asymptomatic and anemia is also absent. The Hb pattern will be normal, and they are diagnosed only by globin chain synthesis analysis. So the second type of beta thalassemia is thalassemia trait, where there will be mild anemia, a microcytic hypochromic RBCs, and they will not require any blood transfusion, and HbA2 levels will be elevated more than 3.4%. So this is about the thalassemia trait. So the third type of beta thalassemia is thalassemia intermedia, where there will be moderate anemia and not dependent on the blood transfusion for their survival, and they will require occasional transfusion, and HbF will be elevated. And the last type of beta thalassemia is thalassemia major. The thalassemia major patients are dependent on blood transfusion for their survival, and they require multiple transfusions, and there will be markedly elevated HbF. So regarding the pathophysiology of thalassemia, the beta globin chains are reduced. So there will be excess unpaired alpha chains. So there will be insoluble inclusions precipitation. So these insoluble inclusion precipitation, they'll have four functions. That is, one is they'll interfere with cell division. Second one is there'll be damage of cell membranes. Third is there'll be reduced RBC deformability, and fourth is there is disruption of the internal ionic environment. So all these four functions of the insoluble inclusions precipitation will lead to intramedullary death of the erythroid cells, which is also called as ineffective erythropoiesis. So finally, this ineffective erythropoiesis will lead to medullary and extramedullary erythroid hyperplasia. So due to this, the patient will present with bone changes, malar prominence, skull changes, hepatomegaly, splenomegaly, persistent progressive anemia, etc. So the presentation of thalassemia will be severe pallor, symptoms of anemia like irritability, intolerance to exercise, heart murmur, etc. Then hepatosplenomegaly will be present, and there will be a mild to moderate icterus due to iron overload and liver dysfunction. The hemolytic or chipmunk facies, patient will have characteristic hemolytic or chipmunk facies. So hemolytic facies means there will be three characteristic features. One is there will be frontal bossing and depressed nasal bridge. Second is there will be prominent facial bones and caput quadratum, and third is dental malocclusion and protrusion of the teeth. And there will be hyperuricemia and bony abnormalities due to extramedullary hematopoiesis. So these will be the presentation of a thalassemic patient. And regarding the investigations of thalassemia, first CBC is done, then peripheral smear, then high performance liquid chromatography HPLC, and then iron studies and osmotic fragility test, and then finally X-ray of the skull. So investigations of thalassemia include, so first CBC. So in CBC, HP ranges from 2 to 8 grams per deciliter. MCV, MCH will be very less. Reticulocyte count will be elevated, and there will be leukocytosis with shift to the left, and platelet count is normal. And the peripheral smear will show marked hypochromasia on microcytes, nucleated RBCs, basophilic stippling, and immature leukocytes. So HPLC, that is high performance liquid chromatography, will show hemoglobin electrophoresis in HbF, HbA, HbA2 estimation, and this hemoglobin electrophoresis is going to be the gold standard test for the diagnosis of thalassemia. And the iron studies will show increased serum iron, total iron binding capacity will be normal, serum ferritin will be increased. The osmotic fragility test will show reduced fragility. X-ray skull will show hair on end appearance due to widening of the diploic space. So these are all about the investigations. So regarding the treatment of thalassemia, so for thalassemia major, the management should include correction of anemia by packed red blood cell transfusions, then management of complications of the blood transfusions, and then management of transfusion transmitted diseases like hepatitis B, hepatitis C, HIV, malaria, cytomegalovirus, Yersinia, then removal of excess iron by chelation therapy, and then management of endocrine and cardiac complications. So for the management of endocrine and cardiac complications, the curative treatment will be bone marrow therapy and SCT, and hypersplenism, if it is present, then there is a role for splenectomy also. Then regarding management of other complications like what all other complications will have to be managed while treating for thalassemia include gallstones, anemia, hypoxia, leg ulcers, pharmacological methods to increase gamma chain synthesis, and the future treatment will include gene replacement therapy, intrauterine BMT, then prevention of disease by antenatal diagnosis and genetic counseling, and then hydroxyurea 15 to 20 mg per kg per day will be given to increase HbF and reduce the need for blood transfusion in other thalassemic states. So regarding complications of thalassemia, the complications of thalassemia include iron overload, which is treated with chelation therapy with desferrioxamine, then hypersplenism, in osteoporosis and osteopenia, extramedullary hematopoiesis, blood transfusion related reactions and infections, and then psychological complications.